So we'll begin with the next session, which is the last session for today, the next 45 minutes. And before this, we were basically giving you an overview on the AMR and why surveillance is important. But when we talk about surveillance, we need to step back a bit and see whether the laboratories are even prepared to do the testing. So that's where is our 0 point or starting point. If the labs are having the right kind of structure in place, infrastructure, the researchers are well trained, are they compliant with guidelines? Are they aware of what are the various definitions? Are they even testing at first place for AMR, or as we say, AST, antimicrobial susceptibility testing? So that is important. So in the next few minutes, 30 minutes, 40 minutes, we'll discuss the various lab methods and the definitions. Now, as you know, most of you who are coming from the healthcare background, when I say how do you detect AMR, you basically detect it by some kind of a lab technique. It's only tested in the lab. And the age-old method has been the phenotypic method. I mean, that's where we all have done our studies on. The culture-based methods, which is very traditional. You can see on the slide, I've kind of grouped it into 3 different categories. So in the culture-based method, or you as say the phenotypic method, one is the disk diffusion. Now, disk diffusion is basically very straightforward. You have your culture plates, you put a lawn of the microbe. So mostly when I say microbe, I'll be talking about the bacteria. So you put a bacterial lawn on the culture plate, and then you put, you must be seeing it in pictures, you put discs of antibiotics on that culture plate. A big culture plate can take more antibiotics. A small one would take about maybe not more than 6 antimicrobial discs. So you put that on your culture plate, and then you leave it overnight and look for where are the zones of inhibition happening and what is the radius of this zone of inhibition. This is basically a fight between the bacteria and the drug. So this is the meaning of disk diffusion. So the antimicrobial or the antibiotic from the disk will diffuse out overnight, and the bacterial lawn, which is there on the plate, that's going to then kind of be a war between these two. And if the bacteria is victorious, then of course what's going to happen is that you would see that the zone would be, there would be no zone around the disc, because the bacteria is so resistant, the drug has been ineffective. But on the other other side of the spectrum, it could be that your drug is really effective. It has percolated in the media, and the bacteria has got killed. So you'll see very, very huge zones of clearance around the disc. And this basically is happening because the antimicrobial, which is in the disc, has been effective in killing the bacteria. So this is a typical situation where you would see a sensitivity or a susceptibility. So that is how in the lab, basically the lab technicians and the doctors in the lab, they eyeball the culture plate, and then they can say, okay, say for example, Pseudomonas and a carbapenem has been tested, they can say it's resistant or it's sensitive. Now, This is actually not a very right method, though we do that. The best is also to use a caliper or a scale to note down the exact zone of inhibition which is around the disc and note it down. Now, again, we'll discuss the importance of this later when I have my other sessions on Friday. And we'll tell you why is it important to note down the zone of inhibition. So this is about disc diffusion. Then you have another kind of phenotypic detection method, which is your microdilution method. Now, this is slightly different. Here, what we are trying to do is we are trying to basically have dilutions of your antimicrobials and bacterial isolates and look into clearing. Also, this is for your MIC detection. Now, again, we'll not get into that detail, but I think it's just important to tell what exactly is MIC and what is a breakpoint. So a breakpoint is basically the name itself indicates. A breakpoint is a predefined concentration of antibiotic. It's like a threshold. So generally, the breakpoints are already listed. They're provided by guidance documents. And then using that, you do your test. And then you look for the MIC, or the minimum inhibitory concentration. And this is basically defined as the lowest concentration of an antibiotic, which is required to inhibit the growth of the bacteria. Now, if the MIC is less than your breakpoint, then we say that the bacteria is susceptible. If the MIC is more than the predefined breakpoint or the cutoff, we say it's intermediate or resistant, depending on the degree of MIC elevation. Now, these things are important, and why are they important? Is because based on the MIC value, we can then guide or tell the clinician whether he should be using a particular antibiotic or moving to consider another antibiotic for his for patient's treatment. And this is again, in a way, guiding stewardship because you're not blindly, the doctor is not blindly just prescribing, he is basing his decision of treating the patient based on this MIC value which is coming out from the lab. So it's again evidence for him to work on. It's not misuse of antimicrobial in the lab, and again helping in building good stewardship practices in the hospital. Now, another culture-based method is the automated one. We do know there are lots of these gadgets there. Phoenix, Vitek 2, Microscan. Again, today's discussion is not meant to describe all this, but for you just to know that these are the three main kinds of systems which are there. Depending on the facility, a facility which is, say, in a remote village, they may not have that kind of funding and they may not be able to really afford automated systems. So yes, they would stick to diffusion most likely. Even the microdilutions are not all that simple. They do require resources. It's a little intensive. And it again depends from facility to facility what is ideal for their situation. Still, at least something should be there so that whatever report is there at the end of the diagnosis and diagnostic testing, it is based on some kind of evidence. Now, other than the phenotypic methods, we also have genotypic methods or the molecular methods for detecting the antibiotic resistance genes. And this list may not be comprehensive, but I just wanted to show it up here because, of course, we are talking about AMR, and for that, we need to know what are the various ways that we check for resistance on the molecular side. Uh, Again, another thing which I would like to maybe encourage all of you to do, and for those who would be interested, is you can always look into the literature more around, what are the different kinds of resistance genes. We have new ones also now. I mean, at the time when I did my medicine, uh, this was really not that much in discussion, but over the last now 2 decades, things have really changed. And I think every 2 weeks we hear of some new resistance mechanism that's being discovered by the scientists. And it's really important, to keep up to date with all these kinds, especially if you're into lab and in testing. Now, starting with right on the top, I've mentioned microarrays and hybridization. Now, these are not very expensive. They are low-cost investments, and that's the biggest advantage. So each of these methods that have been mentioned, they have their own pros and they have their own cons. So depending on, of course, what is the financial is backing at the institution. If it's like a high-tech place, you could be having the best of techniques being done in the lab. Otherwise, they can also just do a simple PCR. So PCR, we all know, is basically you just amplifying the nucleic acid, also called as NAMs, the nucleic acid amplification techniques. And that used to be done even many, many years back, still being done. And the other new thing that is there now is the metagenomics. That's a kind of next-gen sequencing, NGS, which is of two types, whole and metagenome. What's the difference between whole and metagenome? Now, when we say WGS or whole genome sequencing, it's about sequencing the full genome of one organism, just one. But metagenome basically means analyzing the genomes of multiple organisms within a particular environment. So you are having lots of different bacteria out there, and their genomes are getting. So that is meta, and whole means only for one. Then you also have the mass spectrometry-based methods. Commonly, you would have heard the terms MALDI-TOF, MS. This is laser desorption techniques, and these are also very popular for detection of antibiotic resistance genes. Now, coming to the mass spectrometry, though they do detect resistance, it's basically detection of resistance-related proteins. It may not capture new genetic mutations which are responsible for resistance. So that's the cons for the mass spectrometry. And of course, in the last few years, we all know about various bioinformatic approaches which have come up, biosensors, nanotechnology, all these things are also evolving. And the focus of today's talk is not to get into these details, but for you just to have an overview of various kinds of genotypic methods which do exist. It would be important, of course, to mention about CRISPR, which is clustered repetitive interspaced short palindromic repeats. Very important, it's a kind of gene editing, a very new technology, looks promising, may have some ethical issues around it, which of course would be left best in, at the hands of the scientists and other researchers to decide. But looks to be a very promising technique to detect antibiotic resistance. and of course, machine learning and predictive analytics. So this was just to let you know about our detection AMR techniques. Phenotypic, the simple one. Genotypic, of course, more specific, more sensitive. Now we move to the terminologies MDR, XDR, and PDR. You all would have heard of these. I would just give a very quick talk about how do you define these based on the CDC and ECDC 2011 document. And as you can see on this slide of mine, I have divided it into a few columns and rows. And on the columns, I'm talking about the categories of antimicrobials. I've listed them from 1 to the last one, which I'm calling as category X. And penultimate to that is X minus 1, and before that X minus 2, like that. And then each category will have different antimicrobials or agents. For example, let's say category 1 is macrolides. So agent 1 could be erythromycin, agent 2 could be some other macrolide. Likewise, we have these different kinds of antimicrobial categories and their specific drugs. So that's about the columns. And then we have the rows. We have the MDR, XDR, and PDR. These are the ones which we typically are talking about these days. Now, when do you say that a bug or a bacteria is MDR? So as per the guidance which has been provided, MDR is when the bug is non-susceptible. That basically means resistant. Or intermediate for resistance. So we just, for the sake of this conversation, we use non-susceptibility similar to resistance. If a bug has got a resistance to at least one agent in 3 or more antimicrobial categories, it's called as MDR. So you can see that I have put a resistance symbol R in 3 of these categories for each of these for each of these agents. So that is what's the meaning of MDR. It could be more than 3, but at least for 3 different categories, there should be resistance. That is MDR. Now, XDR is on the other side of the spectrum. What happens here? It's resistant to at least one agent in all but 2 or fewer antimicrobial categories. As a result, if you see that I have basically left the last category and the penultimate category, I've not put a resistance R over there, and I'm showing that for all the rest of the categories, that is up to category X minus 2, and at least for one agent in that category, there is a resistance. And then we come to pan-drug. The name is implied. It's resistance to every agent in every category. So these are basically standard definitions. However, I would encourage you also to read this. And I think this is very important, especially when you will be talking about working on AMR surveillance. These definitions may change, may evolve, but it's important to be abreast with these definitions and guidance documents. And also it's important, so again, the purpose of my discussions today is to give you an overview of AMR. AMR is just not one thing, it has a lot of technicalities around it, and that's what we have just discussed right now. Also for you, from a global health perspective, to be aware about the various documents. Each of this document has has its own objective, and I think it's very important for anybody interested in the space of AMR to be aware about the content. Of course, you need not read cover to cover, but you must know what was the essence behind that particular document. So, for example, the Global Action Plan on AMR, a WHO document which came up in April 2015, I think. Uh, this lays out a guidance for all the countries to create their own national action plan. And it again talks about strategies, 5 different strategies on which the focus should be done by the countries. So we have strategy 1, which is awareness. 2 is about lab and surveillance. So again, my talk is on strategy 2, which is lab and surveillance. Strategy 3 is about your infection prevention. 4 is stewardship. 5 is more into research. So like that, we have every document, having a different kind of a focus. We also know about the WHO Aware antibiotic book, which has been released recently after the changes which was done earlier, I think in 2018. And again, here the focus is about which antibiotics does WHO deem should be considered as the first resource, means access, and they should be available. Mostly those are the ones which should be the first drug of choice. Watch are at a mid-level. Reserve should be always reserved, never prescribed unless and until really warranted, based on the level of resistance that is these days being seen for those various antimicrobials. Hence, that's the category that WHO has recommended. Of course, this will also evolve. Few drugs may go, on either side. That time will tell. But that's a guidance which countries are being encouraged to follow. I was also talking about the guidance, the WHO toolkit on stewardship. So that's again a very important document, essential for all those who are working in the space of AMR to be familiar with this toolkit. It's something, if you just read through this on your own, you can start creating a stewardship program in your hospital. I don't think you need advice or suggestions from anybody if you have this toolkit well read through. It's just very easy to implement it if you have read that one. I'm sure all of you are aware of also the new WHO bacterial priority pathogen list, which has come out in this year, 2024. That's the last little graph which is here. The prior one had a longer list of bugs. The newer one has a slightly tweaked list. Some bugs have been removed because it made less sense to keep them in the new category. But this is also important because that's what research. So now, why did this happen? This again has happened because of surveillance. And here is again the role of surveillance. Until surveillance is done, we would not have the evidence to decide changes in our policies, in our way of functioning. So again, here lies the importance of surveillance. Also very important documents, some of these which are here. I've actually just put up a few really essential ones, which I think we all should be aware of, especially the new and budding researchers who are entering the AMR space. You must look into the model list of essential medicines. It does specify very clearly which drug to be given for which clinical condition, and what not to be given, takes into account various factors like patients' health conditions. So again, essential stuff for it, not necessarily for you to be from the medical fraternity, but in general, as an AMR champion, an AMR stakeholder, it's good to be aware and abreast of main things and key takeaways from each of these documents. And I did mention about the political declaration on AMR at the high-level meeting, which was held in end of September, on the 26th of September in New York. So that event and many such events which have been happening across the world, or maybe just locally in countries, these are important events that are actually trying to drive a national and international cooperation. And as mentioned, there were lots of various key takeaways which came out from the UNGA. And I think all of us who've been following these news, they know that the next thing everyone's saying now is the time to act. But again, when we say now is the time to act, we were acting all along too. But yes, we need to maybe shift the focus a little bit, think about a few more approaches which are more important. Maybe a One Health approach is, of course, more required today instead of working in silo. We also need to improve systems. As I mentioned, surveillance is so important because if this declaration says that we need to cut down deaths by 10%, global AMR-related deaths by 2030, how do you cut that? I mean, do you even know the number of deaths that are there today that we talk about cutting by 10%? So 10% can only apply on a number when you have a number today. So there is the importance of then strengthening our research or strengthening our surveillance systems. So we can say, okay, today it's say X and tomorrow we make it 10% lesser of that X. But that X needs to be identified. And we need to complement, as I said earlier, our modeling work with our real data analysis and building strong surveillance. So surveillance and modeling need to be complementary. Also, I would like to maybe add that AMR is not a problem which can be solved. AMR is a problem which can be mitigated. So we need to also be very clear on, what are the kinds of advocacy documents we are making, and very making guided efforts and well-informed decisions. So coming to the surveillance platforms, which are the surveillance platforms? And this was one of the questions which came up by one of our members who participated, and I talked about these four in that response. The global one is GLASS by the WHO. They also have an antimicrobial use added to it. When it began, it was only talking of the resistance surveillance. Now it talks of use surveillance also. Also, it's following now a One Health approach. So that's good, and it's helping countries. So if your country is participating, do remember it's a country which participates in GLASS. It's not a lab alone which can. It goes through a national level. So it also helps you to understand the methodology. So somebody did ask that, do we have any surveillance guidance? GLASS does provide these kinds of guidance, so those can be looked into. And then you can always customize it as for however you think is best for your context. In Central Asia and Europe, we call it CSER. In Europe, we call it EARSnet, that's the European AMR Surveillance Network. In Latin America, we call that the RELAVRA. And as I said earlier, we also have various industry-funded surveillance platforms. So we have actually quite on time and we are done. This was basically, today's chat was more around an overview, a global lens, the weaknesses in our health systems, and why all this? Because I want to bring out from today's talk the importance of AMR surveillance. And tomorrow onwards, we are going to go into all the steps of surveillance one by one, and then that's the way forward. So I'll close my talk now, but I'll be open for questions from all of you. Thank you.
We do have a number of questions from the online audience. Thank you, Dr. Kapoor. Just to kick off here, somebody writes that we use antibiotics mostly in empirical therapy, but culture and sensitivity are rarely done. After we get a report of culture and sensitivity, most antibiotics show resistance. What may be the effective use of an antimicrobial so that we can get a better result during treatment without antimicrobial resistance? Is there any kind of guideline?
Could you repeat the last part, please? What?
What is the optimal effective use of the antimicrobial so that we could get a better result during treatment and not have resistance, because resistance is so common?
Right. So, again, once the resistance has shown, can it get reversed? There have been studies which shows that yes, it can be. Some drugs have become more effective now than they weren't earlier. However, important thing is to cut down on the predisposing factors. So as I mentioned, and I'll get back on the first slide, which I had shown on what is accelerating AMR. And these are on my slide right now, various factors that are accelerating. So as you mentioned, resistance is coming out really commonly. How do you and what do you do about it? So you have to at least build in some ways that at first place you don't catch the infection. You need to improve your infection control policies in your institution, in your communities. You need to have better wash practices. See to it the vaccination coverage is good. These are ways, these are more of preventative measures. Why do you even want a situation to arise? So at first place, let's try to see to it that we try to prevent the situation from arising, or even if it has to arise, it should not be at an accelerated mode. It should be at a mode which is more natural phenomena of the bacteria. We are not messing it up with our man-made measures. So that is the only way that can be done. Two, the antimicrobials need to be used less in just not the hospital, but even at the community level. Again, just not in human health, but across all the sectors. Their management of antimicrobials, how do you dispose it? You need to look into that. As I said, we need to cut the interaction between the antimicrobial and the microbe to a large extent. Now, having said that, I also wish to clear here that the clinician's advice should always be supreme. So even though today, sitting here, I might say that, okay, don't do this, don't do that, but yes, if the doctor thinks that for his patient he needs to give, I think that is always supreme. So at no point am I advocating against the clinician's advice. That always reigns supreme. So we need to always maintain that. But yes, as a global health person and as a researcher, we have to make our utmost efforts to see that we try to reduce this interaction between microbes and antimicrobials to reduce the resistance.
Great.
Thank you so much. I'm just wondering, since you've pointed out several surveillance sort of resources, they very often, and it's a normal thing that surveillance, especially on national or global level, it's very much focused on resistance prevalence, so resistance results and things like that. Very often it's aggregated and it sort of leaves out clinical, epidemiological factors to it, sorts of infection, diagnosis, like all those things that are very important to understand in order to action against it. So I'm wondering whether you have experience or any thoughts on how we can incorporate all of those more extended information into surveillance? And obviously, it's very costly, and I appreciate it, but I'm wondering if you have any experience.
Yeah, so when you do a surveillance study, and we did that as a part of our organizational work, we have done lots of surveillance studies. The kind of data that you actually get on the ground, it's very variable. So one center may give you exactly what you desire, that exceptional case, that, okay, I needed to know my patient's clinical profile, morbidity status, everything, whether he was on a device, was he having any infections which were device related, what about his antimicrobial usage, all that kind of different data, that's like exactly what we wanted, straight out of the book. But honestly, very few centers would give you that information, as I mentioned. You even if you just get age and gender and the resistance rates, that itself is a lot to get, even if you get that. But again, the AST data that you're getting should also be done following all quality guidance. Many times you don't even get that. You may have issues with the kind of data which the lab is giving it to you, especially if the data is retrospective. You have no way of cross-checking or getting it rechecked. You have to go by what's given. So again, it's so important to state your disclaimers and to make it very clear that we can explain as much as we could get, and the quality of the data, you can only believe it. You can't get it retested because now that was say 8 years old or 2 years old or whatever. Prospectively, it's very easy to kind of improve your systems. But going back, but even then, the best thing is you start somewhere. Even if you say it was not good, but we start somewhere. You kind of established a system which was never there, or you're finding the gaps, which is so important to improve your systems for future surveillance. So a start is that the baby has started, walking is important, and then you keep guiding the entire course and everything. That's important. So we do find a lot of, in my experiences, we do find challenges. You may not get an ultimate situation would be everything is electronically linked. The pharmacy records, the lab records, the clinical records, everything is linked. All the patient parameters are complete. I have everything that will give me the real prevalence of it. But that does not happen. That doesn't exist. So whatever bits and pieces you're getting, you have to join the dots. Also, here comes the importance of, and we'll talk about that in our subsequent sessions, comes the importance of how do you finally show your results, the resistance rate, what kind of confidence you have in telling that this is my resistance is 30%, or is it 70%? Are you confident? So your confidence interval also has to be very well defined. Do you follow any innovative way to say? So there are different ways of representing your confidence interval. But again, you need a statistician on board to kind of guide you on what is the right approach. As I said, all these programs, everybody brings something new on the table. So in one of my studies, which I did, my statistician suggested, okay, let's not go with the conventional confidence interval method, because that is pretty age old, and that doesn't really give you a good, because anyways the data may not be very representative. How do we generalize the findings? So they decided, they did another study to kind of get a different kind of a range. So lots of challenges for sure are there, and that's why we are here.
Thank you.
Thank you. So given that excessive antibiotic use is one of the drivers of AMR, and in Africa, a lot of the antibiotic uses of prescription or consumption is primarily in the communities. both through patent medicine dealers and also even physicians who in centers where there's no access to many of the diagnostics that are available. And are there strategies or are there point of care tests or tools that can be used to, at the barest minimum, distinguish between, for example, bacterial or non-bacterial causes of an infection? Because in that situation, then the doctor would then have more confidence to prescribe or not to prescribe antibiotics.
Yeah, so
So my question is, are there strategies or are there point of care tests that are particularly suited for resource limited contexts and like Africa that can, if not determine the antibiotic resistant profile, but can distinguish between viral and bacterial causes of, for example, respiratory infections?
look, for cases like sepsis, which is a very important cause of death, we do have POCTs. For example, you have your procalcitonin and your CRPs. These can be used. They at least tell you whether the patient is having sepsis, and then for sure you need to empirically immediately start the antimicrobial. So we have those kinds of testing. You also have these newer the genomic studies have shown your metagenomics and your whole genome sequence, and you can do that, and that also can be converted to like a point of care testing, quick results. It's there in TB also. You have your point of care test. You immediately say, okay, well, this neuropathos, so those kinds of, again, they have genotypic element to it, but phenotypically, you don't have any point of care testing. Everything is going to take its own 48 hours or 24 hours of incubation because the bacteria takes that much time to go on a culture plate. So all these point of cares are basically molecular markers and genotypic level of testing. Those are the ones which need to be. So again, that's where a lot of investment is going to take to build up those platforms.
Questions here from the online audience. Somebody is asking, is antimicrobial residue testing in frozen animal foods imported into a country a relevant parameter for AMR surveillance for regulatory control?
That's right. We do need to have regulations on our residues also in the animal sector. So in fact, as AMR is the One Health problem, and you have to work intersectorally. You need to not just focus on human health, and that's why we are having the quadripartite also now, working on how to bring intersectoral guidance to inform each other.
And more from the audience here online. Somebody's asking, is there a need for an AMR global action plan?
We already have one. We have a global action plan which came up, and I mentioned about that in one of my slides in 2015. We need one One Health global action plan that is more around, of course, it's covered all the domains, but it needs to evolve further. What it lacked was the budgetary and the financial picture. It had more of activities and intended activities, programmatic approach, but the missing bit was, of course, so every document starts from a zero version, it moves to the next version, and I believe that is also in making. So, yeah.
And continuing on from the online audience, somebody is asking, human AMR studies are largely performed worldwide, overlooking the animal AMR surveillance. This outlook exacerbates AMR burden. What are the future opportunities in collaboration in One Health projects globally?
Yeah, so that's going on. I mean, lots of funding opportunities which have come of late, including the Trinity Challenge and various other funding calls. that even I keep looking into, they are having a One Health focus. It's talking about collaborations across sectors, uh, because you cannot solve, first of all, you can't solve AMR. So again, I'll always reword if it's not a solvable problem. It's a problem that can be curtailed to a large extent if we do have good coordination between various domains of One Health. And you need to tie up on similar surveillance, so you can maybe think about some innovative studies in the future where you say, okay, I'm going to strengthen surveillance in human health through this approach. How do I tie up? I mean, you need to do some kind of linking of the origin, if this AMR gene has originated in animal health, or is it in the human sector, that kind of. So again, genomics helps. Metagenomics really helps us in kind of joining these dots. Where did the gene originate? What path did it take to move from one sector to the other? Those kinds of programs are needed.
Another question online. How can the variability in laboratory testing methodologies, antibiotic prescription practices, and data reporting across different regions and healthcare settings impact the accuracy and comparability of antimicrobial resistance surveillance data globally?
A lot it impacts. That's a big cause of, so we do encourage that one, the labs should always comply to international guidance, standing practices, whether you follow CLSI or UCAS or any other, please follow, the labs must follow some guidance. And the best would be if all the labs in a country also adhere to the same guidance. If some labs in one country are following UCAS and some are following CLSI, again, it's tricky to kind of, combine these results. It's not that you cannot, you can with the caveat, but it's good that they follow. So we should encourage that. In fact, even countries in the same region, like the Francophone countries usually are following at the UCAS, or there is the CASFM, they also follow that. But we should encourage that at least in the same region, they should adhere to the same kinds of guidance. Again, for ease of comparability.
Great. Another question from the audience. There is a need to strengthen the relationship between animal sector and the human sector as a One Health approach. As we know, animals are a major source of AMR burden transferred to humans. What institutions are in place to link this gap globally?
The quadripartite is there. They have established that, and that, as I said, quadripartite contains the WHO, the OIE, which was earlier by the name of Organization for Animal Health. OIE is the old name. The new name is the World Organization for Animal Health, the FAO, and your UNEP. So these four institutions are together engaged and helping to track surveillance, strengthen surveillance, and working in collaboration. So I think we are really going to leverage a lot that's happening, and next few years we'll see even more amazing proposals coming up.
Question. How can AMR data be collected across sectors and reported in one health system? Are there any surveillance systems linking animal health, human health, and environmental data?
So the tracks, I'll encourage you to look into the tracks, which is going to be tracking, which is tracking the surveillance in these various sectors. Again, it's by the WHO. Really gives a very good picture of compliance to various policies and what are the gaps and how do you improve this further. It's at a country level, and encourage you all to look into the tracks, TRACS.
Question, is there any AMR surveillance and AMU surveillance in Africa?
There are lots of programs that are happening. In fact, I would say that Africa is doing really well. They have a lot of good leadership out there. A lot of funding coming as well. I had the opportunity to also, support the surveillance programs over the last few years. And I must say that they are really forthcoming in improving surveillance, AMR surveillance across all the different domains. So Africa is doing well as far as strengthening AMR surveillance systems. So a lot of capacity building programs are happening over there. A lot of country fellowships are there. Fleming Fund is really investing a lot in improving not just Africa, Asian programs also, but yes, Africa is really doing well as far as their efforts are there. A lot of advocacy going on. You have the Africa CDC, which is the health arm of the Africa Union, dedicated body to improve the global health and the health sectors across One Health. So I think really nice pioneering efforts are happening there.
Great. And someone is asking, is there a centralized system for the collection of AMR reports across regions of the world?
Again, it depends upon, what kind of platform are you going to finally send your reports to? If you are, say, sending it to GLAS, for example, I can maybe share an example from India, from where I am. We do have labs, which few specified labs, which are, they're feeding into the GLAS database. So few selected labs, which are under the Ministry of Health, they have been selected, and data from them regularly goes to the GLAS platform. And over the years, more labs have also been added, and all these labs are doing good quality testing. So again, there is no one answer to your question. These systems need to be developed, and it all will depend upon the Ministry of Health of your country. They need to get engaged, and I'm sure they are already engaged, and try to increase the catchment area. More and more labs, if they get added to the GLAS network, that would be so ideal.
Some questions here. In LMICs, primary healthcare uses algorithms to diagnose and treat childhood illnesses using antibiotics. Is that not an accelerator to AMR? What can be done about this? To what extent should countries use these algorithms?
So are you kind of referring to empirical guidelines? I'm not sure about what did you mean by that, but empirical guidelines are always there in any center, in any region, country, hospital. That's the way we need to first proceed, but of course, tailor your drugs based on reports from after the lab results out. That's important, and that's what stewardship is all about. Again, the clinician's decision is going to always be important. I don't think any global health person can actually tell the doctor how he should be treating his patient because he knows that. But yes, having said that, we need to encourage and bring to light the importance of curtailing AMR through good stewardship practices.
Great. And another question, how can we help globally the developing countries like Malawi, for example, in Africa, where most of the hospitals fail to monitor AMR except few central hospitals? Is there any specific support for microbiology laboratories?
Right. So, I think I mentioned this earlier. We are having a lot of capacity building programs happening. I would encourage, and I know Malawi is doing good. Actually, most of your Malawi global health professionals, they have really worked very hard in bringing the country to a very much better level than rest of the world is. So they are showing that spirit, and the concept of mentorship is also important here. Uh, other settings, which are really performing well, have strong surveillance systems, they should be mentoring the low resource or resource constrained settings and kind of guiding them on building. So this kind of shadowing of one center by the other is also important in resource constrained settings for strengthening your surveillance partnership. So that kind of approach might help, and that's one of my suggestions.
Question, is there any guidance on having integrated surveillance for AMR and AMC in LMICs?
So I think this is a repetition. We did talk about integrated surveillance is happening through GLASS. GLASS is also having other modules. It's not just restricting itself to human health. We do have that also. So apart from that, I think at national level and regional levels also, we are having integrated surveillance. But of course, systems are evolving. And you can also look into if you have any regional platform at your center. So I'm not sure if you're from which country, but do look into any regional platforms that you can also join. That will also encourage and strengthen your surveillance systems.
Okay, I think we've come to the end of the online questions. If there aren't any more from the audience, we can thank our speaker for coming. Thank you.